So let's start today's session. So I will present a case. So as per our earlier discussion, we will talk about the case, and then in between the case, I will revise your module. So those who had not revised the detoxification module in a class, then I would highly recommend that you again go back and see all the lectures in detoxification, and then once again you see the this case study, and you will have more idea about what I am talking to here. Back to present the case of 43-year-old male, and he came to us 1.5 year back with the current concern of itching and dark pigmentation. Also, he's complaining about low energy, mood issues. He also complained about constipation, and also he noticed his urine is darker many a times, even he is on a good water intake. Okay, so if you see the timeline, then I'd shown the current concern that was itching and dark pigmentation, fatigue, and all the symptoms are there. And then we look at the antecedent, trigger, and mediator. So here you can see the antecedent. He has a family history of cancer, depression, eczema, and jaundice. I had not mentioned over here, but the cancer and depression came from his father. His father is having a cancer and depression, and jaundice and eczema he is getting from his mother. So the family history that we consider as an antecedent. Also, we have another antecedent we had mentioned over here, and that is cesarean section. So he's born with cesarean section, and now we know that CS could be the risk of any kind of inflammatory disease or inflammation later in life, because that also important for creating the healthy immune system over there. So if somebody born with cesarean section, we would like to look at the gut microbiome. That's what he said, and then he started having some issue with the itching very early in his life. At the age of 13 and puberty, he started having skin issues. Particularly, he is complaining about itching a lot of time, but nobody had diagnosed why he has a lot of itching, and many times he got to dermatologists and they are diagnosed it may be the eczema or allergy. And then also he has a one episode of jaundice, and that was jaundice was a very mild, so he has not taken any treatment for that, but he remembered that he got an jaundice diagnosed by a family physician or family doctor. And then everything was fine, but he had started his career as a pilot. So he had moved to US and he had started his career and studying and joined the course in aviation, and then he became a pilot. So when he came back to India, he's already a pilot, and then what I noticed is he has a sinus surgery for the polyp, and so he came back to India and he's doing his job, but he got a frequent allergy issue and sinusitis, and he got diagnosed with a polyp, and then he done a surgery at the age of 30. But if you look at back then, he also having multiple episodes of allergic rhinitis and sinusitis. Then he started having an fatigue and mood issues, and for that basically he came to us. So the itching and skin issues are since there many years. Constipation is there also, but he primarily came for his fatigue and low energy and mood issue, and that's what he wanted to diagnose himself. So now if you look at this timeline, then now we know there are some antecedent, trigger, and mediator. So you can see here, I just want to point it out, is that he is working as a pilot. So why I would like to point out these things, because he is exposed to many chemicals. And in aviation or frequent flyer, they are considered to be risk for environmental toxicity, because there are many chemicals they are exposed in the cabin of aeroplane. And then you can look at the polyp surgery and frequent sinusitis. We consider he might be having an exposure to any kind of allergen, or maybe the exposure to a mold or mycotoxin that leads to a chronic sinusitis, and that's why he developed a polyp, and then surgery was done. So here you can see the sinusitis or polyp might be a triggering factor, and with that you can see mediator could be the long-standing exposure to a chemical. So as we had discussed in our module, that when you look at the detoxification or any kind of toxic exposure, we consider that total burden in the body is not just the exposure. So total exposure minus capacity of patient to detoxify that chemical. So we consider both the things. So let's say for example, let's say if two people are exposed to any kind of toxins, chemical toxins or pesticide, whatever toxins you can think about, but if they are good in nutrition, if they are having a good ability to detoxify that toxins, then they will not develop the symptoms, or their liver is capable of eliminating toxins. And that's why you can see over here there are antecedent, trigger, and mediator. So once we have idea about what are dysfunction, so in this case you can see all the lab we're going to interpret, not the detoxification. We're going to interpret all the biomarkers that we have done with this patient. But if you look at this dysfunction, then you can see there are 4 dysfunction that is confirmed dysfunction, like, and one is cardiovascular. Then you can see liver and gallbladder, and immune dysfunction is there. But you can see the rest of dysfunction are in probability, means probably they are not in that dysfunction. But typically in this patient or this lab, we're going to focus on a 4 dysfunction. And if you combine the liver and gallbladder dysfunction, then you can combine as a detoxification function. So you can see that this patient having an immune, cardiovascular, and this patient having a detox issue over there. Now you can see we will interpret all the dysfunction, like you can see sugar dysfunction. So all the markers of sugar dysfunction, they are in optimal range. So we consider this patient doesn't have any issue with their sugar metabolism, and everything look like normal. Even you can see kidney functions are normal. Again, when we talk about the detoxification, we not only talk about the liver, because kidney is also important for detoxification, right? And as we had discussed earlier in a recording, that majority we have 2 kind of toxins. One is a water soluble and other is a fat soluble. And you can see kidney is in charge of water soluble toxins, and we will not worry about the water soluble toxins, because our kidney, and if you take a good amount of water, and if you take care of basic minerals, sodium, potassium, magnesium, and calcium, then you can detoxify the water soluble toxins from your kidney. Majority toxins that what we are discussing here as a chemical, they are actually fat soluble, or we can say they are lipid soluble. So, and that's why we are worried about them, because in that case our liver is in charge of detoxification of that xenobiotics. Okay, so you can see here the sodium and potassium is slightly on lower side, while the sodium is slightly on higher side. So why this is important? Because as I mentioned you that basic minerals like potassium and magnesium, they are intracellular, while the sodium and the calcium, they are the extracellular. So we have to increase the potassium and we have to manage the sodium. But when you look at this electrolyte imbalance, don't consider that patient having a chronic deficiency or chronic excess of sodium and potassium, because it is serum. So somebody taken some kind of salt earlier, then they might be having a high sodium. So we look at the serum level of sodium and potassium just to find out whether what we want to correct it. Now you look at the protein, and protein you can see is in optimal range. Like total protein is 6.9, that we consider is optimal. His albumin level is also 4.7, that is optimal. And you can see globulin level is slightly on lower side, but we will not worry about these things because his total protein and albumin level is normal and optimal. So it's slightly below the optimal range, but that's okay in this case. Now you can see IgE antibodies increase. So as we had discussed earlier, IgE anti stand for allergies. So when somebody exposed to any kind of allergens, they increase their IgE antibody. And when you check it and repeat the level of IgE antibody, you have idea whether the patient having a chronic allergy. So in case of chronic allergy, always the IgE antibody is slightly on higher side. In some patient I have seen the IgE antibody could be more than 1000, but in this case you can see this 371, that is moderately raised. So this patient having a chronic exposure to some kind of allergen, maybe it's a mold or environmental toxins over there. So IgE antibodies increase, and IgE antibody we consider as a allergies. And we can also confirm IgE antibody with an eosinophil count. In this case, I will show you also the eosinophil count. But just for your knowledge, when you look at the IgE antibody coming from the mast cell, and mast cell is primarily coming from your eosinophil. So if you just look at the eosinophil count, And if the eosinophil count is increased, then also consider this patient having an allergy. Now look at the basic minerals like calcium is in optimal range, but you can see magnesium level is slightly on lower side. And I just want to show you, yeah, so you can see calcium level is in optimal range, and then magnesium level is below optimal range. So we consider 2.2 level should be more than optimal. But as we discussed earlier, we don't consider serum magnesium is an ideal test for magnesium deficiency. But when you see serum magnesium below optimal or low, consider this patient having a severe magnesium deficiency. Now, today's discussion is on a detoxification. So I would like to discuss each and every biomarker of your liver. So you can see liver biomarker. First biomarker that most commonly we do in a liver is alkaline phosphatase, and you can see in alkaline phosphatase is lower. And in my experience, most of the patient what we do a testing, we find out the low level of alkaline phosphatase. So when you see the low level, you consider patient might be having a zinc deficiency or B6 deficiency, and when the level is high, you consider it as a insulin resistance. But in many cases of insulin resistance, you can also find out the low alkaline phosphatase level. So in that case, you would like to consider them having a zinc or B6 deficiency. And here you can see his patients SGPT and SGOT, they are in optimal range. So, and also the GGT enzyme that is all in optimal range. But here you can just notice that bilirubin level is increased. So you can see the bilirubin level, that's total bilirubin level, direct and indirect. And we'll discuss bilirubin in detail because that's a major pathway involved. But here you can see that this patient never diagnosed with any kind of detoxification pathway issue. And here you can see bilirubin level is higher. So jaundice diagnosis you make when somebody having a high bilirubin plus they have symptoms like you can see the yellow sclera or yellow urine or yellow pigmentation you can see over there. But in this case, the diagnosis is actually a Gilbert syndrome, and Gilbert syndrome is a genetic disorder and where there was some kind of defect in their gene. We will discuss that also, but because of that genetic defect, they have a major issue with an detoxification pathway. Phase 2. We'll talk about phase 2 also. But you are right, this phase 2 pathway, and that phase 2 pathway is glucuronidation, and that's why the bilirubin level is slightly on higher side. And we will discuss also that bilirubin level in detail. But here, you just, with each and every patient, you should look at the bilirubin level. And even you can see the mild elevation in bilirubin, consider this patient having some difficulty in detoxification because bilirubin is a major pathway where we can diagnose even without doing a genetic testing. And another biomarker that GGT, and GGT usually stand for chemical toxicity. So when somebody exposed to any kind of acute chemical, like let's say somebody is working in a farm with an exposure to a pesticide, or somebody working in a chemical factory where they're exposed to a chemical, that GGT enzyme will be higher, around you can see 70-80. Also, you can find out high GGT in insulin resistance and diabetic patients. See, alcohol, when you see alcohol liver disease, alcoholic liver disease, fatty liver or alcoholic liver disease, where you can see elevation of all the enzymes, right? You see high SGPT, high SGOT, even you can see high GGT level. So yes, alcohol consumption is one of the reasons, but that's a chronic alcohol consumption. If somebody is taking alcohol, then you check the liver enzyme, they will be normal. But with somebody having a chronic alcohol consumption, and because of chronic alcohol consumption, if they have some issue with the liver, or we can say alcohol liver disease, then in that case, you can see elevation of SGBT, SGOT, and GGT enzyme also. In that case, their bilirubin level may be a normal. So consider this kind of diagnosis when you see SGBT. But when you see any liver enzyme that is that is high, right? Consider that patient having some issue with the detoxification. See, it may be a fatty liver, means the fat is deposited, so liver will not work very optimally in that case also. If somebody having some chronic inflammation because of any infection, hepatitis B or hepatitis C, they also have some enzyme elevated. Consider in that case also, they have a difficulty in detoxification. And when you obviously see high bilirubin level, consider this patient is having some issue with an genetics. And when you see high GGT, consider this patient having a chronic exposure to chemicals. Now, if you look at his iron level, and then iron level is in optimal range, so we're not worried about the iron. And cholesterol level, you can see the cholesterol level is optimal, but the triglyceride level is slightly on lower side. But the rest of markers are in optimal range, and you can see the HDL level is 77, so we'll not worry about the cholesterol in this case. And also we are seeing that patient doesn't have any kind of insulin resistance, and his LDL level is normal, so we will consider this patient having an normal cholesterol. Not exactly the optimal, but we can consider them nearly normal. And you can see thyroid parameters, like you can see all thyroid parameters, they are in optimal range, TSH, T4, T3, so we consider them, it doesn't have any issue with the thyroid. And now you can see, I just want to point out here that HSCRP is optimal range, but you can see the homocysteine level is 16.02 that we consider to be high. So again, I would like to mention here that many labs consider 30 of homocysteine as a normal, but don't consider that parameter. If you look at the literature, optimal value of homocysteine should be less than 7, optimal. And when you see some level of more than 40 or 30, 40 or 15, consider them as not an optimal level. And somebody having a more than 20, consider they have genetic defect. And in this case, you can see his vitamin D level is 214. So that's high. So we will stop any kind of vitamin D in this case. And we advise the patient to do the testing after 4 or 6 months. But you can see the vitamin B12 and folic acid, they are in optimal range. Now, why this is important? So when you see the normal or high or optimal B12 and folic acid, and the same in the same patient, same time, if you see high homocysteine level, consider this patient having a genetic variation in MTHFR genes. We have discussed the MTHFR gene. I will also point out the homocysteine pathway here. But just in this case, I consider this patient having an genetic defect in his MTHFR. So we'll also discuss the homocysteine pathway in detail. Let's just go with an slides, and we will clear in that way. So now you can see the CBC, and you can see hemoglobin level is okay, and his WBC count is also okay, his NCV and CSC is okay. But I just want to show you over here is his eosinophil count. You can see the eosinophil count is 13%, so that's very high. So optimally the eosinophil count should be less than 3, and when you see more than 3 to 5, you consider moderately increased. But when you see more than 10, consider this patient having a chronic allergies. As we understood in IgE antibody, the half-life of IgE antibody, as we learned in immune module, that half-life of IgE antibody is just 2 to 3 days. And if you see chronically elevation of IgE antibody or eosinophil count, consider this patient might be having an allergy, or they might be getting the allergy from the environment, or they might be getting allergies from their gastrointestinal tract. We consider that as a leaky gut. So if you see all the report, then finally we understood that this patient having an 3 primary dysfunction. As we have discussed over here, the primary dysfunction is immune dysfunction because IgE antibody, eosinophil count is increased. Cardiovascular dysfunction here is mentioned because of high homocysteine level, right? So if you look at the other biomarker like sugar, like his lipid level, they are also in optimal range. But because he is having a high homocysteine, we should consider that high homocysteine is also linked to the cardiovascular disease, because that amino acid homocysteine is increasing the clotting and inflammation and endothelial dysfunction. And liver, we have discussed that patient having a high bilirubin, so he has a major issue with the liver because he also having a high homocysteine that we consider as a methylation defect, and also he is having a Gilbert syndrome. And immune dysfunction already we have discussed, right? So everybody understood that from the biomarker we had find out, even from the history and from the biomarker, we had find out the 3 primary dysfunction: immune, detox, and also we find out the methylation defect.